Good morning. Just feel free to let me know when it's best to begin, and I'll get going whenever y'all are ready. Okay, good morning. I've been asked to go ahead and start this morning, but before we do, there's a chat box. If everyone could please type your name in there, your credentials, title, and your email address for attendance purposes, that would be much appreciated. My name is Clayton Womack, and I'm an acute care pediatric nurse practitioner. I practice at University Medical Center Children's Hospital as part of Texas Tech Physicians Group. I'm one of 2 nurse practitioners and 4 ICU intensivists that practice here in the PICU. And we appreciate you coming out today. And I hope that as we make our way through this lecture, I can hopefully help you guys become more comfortable with care of the little ones. Sometimes you don't see very often, and they're very nerve-wracking. So if you have questions, we can discuss them at the end. Feel free to write them in the chat. I'll try to go back through and answer them as best as I can if there's not a lot to wade through. So where I want to begin is, let me get the hang of Microsoft Teams here. Make sure it moves over. So we're going to start out real briefly discussing the pediatric airway differences, technology and its limitations, and then we'll go through some airway diseases that I chose to kind of pick out that you're likely going to see more of or need to know a little bit about and how to care for them. We'll spend a little bit more time toward the end with maybe bronchiolitis and asthma on those topics, as I feel like those first two are a little self-explanatory. We've all heard about epiglottitis in school. It's probably stuck in our head. As we come through, talking about breathing for anatomy and physiology in infants, it's very important that their nose is kept clear. If you think about it, the first thing we do after an infant is born is immediately bring to the mother's chest, if possible, and attempt to breastfeed within the first few minutes of life so we can create that bond, create that attachment. So obviously, in doing so, our mouth is full, we need to breathe. And so it's very important that after birth, they suck out that nose, get things going. It's the same with our infants. As they come in to the emergency department or your pediatric floor, wherever you practice, to ensure that that airway is open for them to breathe. They do have larger adenoids, that part of the back of that throat, that nose area, are rather large. And so these can cause issues until about 8 years of age. That's why a lot of kids get adenotonsillectomies, things like that. Is sometimes they have a little bit larger airways that cause sleep apnea or obstructions early in life, and they get a referral to ENT. In the mouth, again, the tongue could be larger. It also could be, smaller. The micrognathia in Pierre Robin is more posterior. The jaw could be more posterior with certain disorders. And so all of those can affect the airway of the infant or toddler or child. And so those are things to keep an eye out for. The airway, the larynx, is more interior than adults. So it does make it more difficult for those of us that have to view the airway. In the smaller, younger infants, the epiglottis is longer, narrower, and floppier. And so getting in there is not like an adult where it's a little bit more stiff and rigid. That airway, that epiglottis, can flop around, obstructing view of the cords. And so that's why clinicians sometimes, if they're not well experienced, have a much more difficult time intubating children, and it takes many more attempts to the less skilled clinician who doesn't see it frequently. And it's very nerve-wracking for the nursing staff and the medical staff. And so knowing that as we go in can help us be better prepared. So obviously, obstruction is a big deal in kids. We'll talk real briefly here as well. So different parts of the upper airway, the supraglottic region, the glottic region, the vocal cords and folds, and the subglottic region, all different regions that can cause various obstruction sites. And so all of those make children prone to obstruction. As we said, we'll go and look at a quick list. And so the oral cavity in an infant, that tongue is quite large for the size of the infant. Kids have large heads and we grow into them. And so, we have to think about the anatomy of all of that. There's no teeth where the tongue sits. There's fat pads in an infant's mouth. So again, the mouth is taken up with a lot more things or larger things than, say, an older child or an adult, when you have a much better view of that airway. Talking about the pharynx, just a different position, the angle in which that part of the anatomy is formed. And so again, it comes through and creates a 90-degree angle at the skull base as we get older. The larynx, the vocal cords and cartilage are much more floppy, as we discussed. The epiglottis is narrower and it's a little higher on the neck and pushed up a little bit further. So all these things make it a little bit more difficult for infants and children and the practitioner when dealing with children's airways. And so what is this an issue with? Obviously, some implications or obstructions can occur due to sedation. You give some morphine or you give Benadryl. Those things, depending on the child, some people react differently to medication. So sedation could allow our airway to be a lot more floppy, as we call it, that relaxed airway. When we're sleeping, our airway is much more relaxed. And so the tongue could move back a little bit. And that's why it's important to be recovery positions or side lying sometimes when we're more sleepy. Obviously, sleep, as we discussed there, CNS dysfunction, head injuries, or other CNS disorders that can cause, again, a depressed mental function, traumatic, like I said, traumatic brain injury. Secretions, especially in infants, they create a lot of secretions. They don't manage them quite well sometimes, especially when they're thick. And so those can obstruct, different parts of the airway, and lower airway, upper airway. So very important, as well as foreign objects. Infants and toddlers stick things where they don't belong. And so it's very important to always keep that in mind when seeing these children, as any one of these various things could be the reason for presentation or confounding your appearance that day. So what can we do? Real briefly, positioning is very important. We'll talk about that a little bit. Putting a roll underneath the shoulders, making sure it's not a large roll, not behind the head, not behind the neck, but between the shoulder blades, right about the shoulder blades, to pull that head back a little bit and open that child's and younger infant's airway. Doesn't have to be large, just enough to kind of make things a little bit more in line. Keeping the nose clear, especially in your infant population, it's very important that we do a good job ensuring that we get those boogers and snot and just mucus out of that airway so they can breathe better. At our facility, our nurses are very well comfortable with deep suctioning by taking an inline suctioning catheter that you would use on a trach, or an EP tube that's really small, placing some saline or infant noses into the nose and sucking out and cleaning that airway, and being very easy to do it because the nose do bleed. And so if you have significant issues, there's always a little bit of phenylephrine in the nose that some people use that helps control bleeding, but preferably not get to that point. So that is, if I can't stress anything enough, getting that nose cleared out to get a good exam on your child is really going to be beneficial for you and the care providers caring for that children, and our anxiety. Humidify the air. That the air is dry here in West Texas, eastern New Mexico, especially, sometimes this time of year, the heaters are going. It takes all the humidity out of the air. Ensuring that we have good humidification in these kids is always vital, always important. And clean those humidifiers if we encourage them in homes, because they can grow bacteria and other things that are not beneficial to us. And examine the child in a position of comfort. What does a position of comfort look like? In a parent's arms. If that's where they're happy, because you take a child away, they're going to scream, they're going to look horrible, they're going to be upset. The retractions may be worse, or, they may not be present at baseline. Remove clothing as well. Ask the parents to remove clothing if you can. If the child is in dire straits, then obviously we have to take matters into our own hands. But if we have the opportunity, examining the child in a comfortable state, having the parents pull up the shirt, look at our work of breathing, all of those things are going to be very important in beginning your assessment and ensuring that we're working the right way and caring for these kids during the respiratory season, or any season for that matter. So again, I briefly touched base on it already. Examining child in the parent's arms, if possible, exposing that chest. I always tend to get in front of myself sometimes. My mind loves to go. Where do we look for retractions? And so the suprasternal notch here above, in the neck, above that collarbone region. And so that's one good key area. These will help define, okay, where do I have an obstruction? Or how hard is this child working to breathe? The sternum, looking at that chest, is that sternum really sucking in and moving back and forth? How much movement does it have to it? The intercostal muscles, that's why it's very key and important to always remove clothing articles or pull up the shirt or take that onesie off. Whatever you can do to examine the child, you will get a completely healthy looking infant in a car seat every time until you take that clothing off and look at the child. And then you realize, oh my gosh, we're so far behind, we need help. The diaphragm, the belly, that belly does move a lot. And so knowing what normal looks like and getting an idea of that movement and that work underneath the rib cage, how is that sucking in? And so all of those things are very important to understand where you're at and what's going on with that child. So as you begin implementation of treatments, how are we improving or are we worsening? And again, when a child's screaming and upset, they're always going to look bad. When they're eating, they're going to look bad because you're obstructing the airway with the bottle potentially. And so it's going to look a little worse. A sleeping child, examining a sleeping child is always number one if you can. That will show you because their airway's already soft, they're relaxed, they're breathing. That will tell you a lot if you can view a child in that state before you implement therapy, treatments, exams. And so what are some ways we can determine how we're doing? There's not really a lot other than your eyes. Pulse oximetry is a pitfall, in my opinion, and I constantly have to teach new nurses or anyone. It's difficult to obtain a reading on a child. And so they're moving around. They're constantly, wiggling. We put it on a arm, we put it on the hand, we wrap it around the wrist, and we try whatever we can. You have to remember there's a light and there's a sensor, and they really need to be spaced across from each other. And sometimes in the really small child, that's really hard to do. And it's got to be able to make through the tissue to read what is attached to the hemoglobin molecule, right? It could, if there was a house fire, it simply could be reading 100% because it's saturated with something. It's not necessarily oxygen, so we don't really know. So how good is pulse oximetry? It's only as good as our exam, only as good as the waveform that you get, and the application of it. And I also try to explain to people it is also a 10-second lagged reading. And so if you have a perfect waveform for 10 seconds, that reading you are now getting is 10 seconds old. And so it will fluctuate. And many times when you're bagging a child or you're attempting intubation and the saturations drop and then everyone stops what they're doing, tries to bag the child up, it may take several seconds for you to see an improvement, and just expect that is the technology we're dealing with. So that is one method. It has its flaws. Again, your examination is very vitally important. This is an adjunct to your examination. Capnography. So we use capnography in many places. Most places should at this point. They are on nasal cannulas. They are in line with ventilation. We throw on the little color change device, right after we intubate to see if there's color change to verify correct tube placement along with other things as well. And so the waveform is exactly what it is. It's another, adjunct ability to monitor your airway status. And again, in my opinion, it's a trend. It's a trend, and it will also allow you to verify continued placement of your breathing tube. If it's on a breathing tube or if it's on a patient you're sedating, whatever. It's a waveform that's exhaled, breathed in through the machine. The machine therefore calculates an exhaled end tidal CO2. And so again, I've placed on here a little picture of what it should look like when it's on a monitor if you have that. And again, these here are just trends. This one's happened to be trending up. So there's air trapping or some form or reason that the CO2 is increasing. So again, you take all that information with your exam and then decide what to do with it. Do you need a gas? Do you need Do you need an X-ray if you haven't already had one? Is the breathing worse? All that is valuable. And so you, again, always reassessing our patients, not just trusting what the equipment is telling us, but back to the patient, always what we're taught in school. That's our number one thing we should always be doing, is using our eyes, hands, and ears to reevaluate. So moving on, we're going to talk about croup. Croup is, especially this time of year, we see a lot of, some years more so or less. We've all heard it. Once you hear that characteristic bark, it's, oh, that's croup. And so, again, it can scare a lot of parents. It can scare a lot of people who don't see it very often, because it is very scary sounding. What is this monster that is making this noise? Why are they making it, and what's going on? So in a brand new parent, every time it's all about calming parents down, calming yourself down if it's new as well, and then going through, okay, how do we treat this? So most common cause of infections, infectious airway obstruction, is typically caused by parainfluenza and rhinovirus. There are several other viruses that do cause this. I've seen it with influenza. I've seen it with the novel coronaviruses, not the COVID-19, but those things all can cause airway inflammation. So it's seasonally occurring. On average, 6 months to 3 years are the most affected. And again, that fall and winter time, when everything is just dry, the viruses are coming out. They thrive in the cooler environments, and so that's where we'll start seeing that uptick in your emergency departments or your floors. So some of the symptoms associated with it, again, we've talked about barky cough. They may or may not have a fever, or they typically do, but they may not. And not usually ill appearing. They feel ill, but they don't look septic or like on their deathbed. They shouldn't, per se. Again, the complicated ones, that's a whole nother story, but generalized and croup, no. So the workup, plus or minus a radiograph. And so, I'll show briefly a picture of an X-ray, what it looks like if a chest radiograph is obtained, to determine, okay, is this croup, or is there something we're working on here? And again, exam. What does your exam findings show you? Is there anything else going on wrong with this child? Does the lungs sound good? Are they coarse? I mean, what else is going on with your exam? But typically, the barky cough is a good indicator that you're on the right path. And so this is a radiograph of a child with croup. And so again, we see here this steeple sign, this very thick steeple sign here, that is usually a good indicator that most people tend to look for croup. And so again, plus or minus radiograph, most people still do, because they're trying to look for an obstruction. Again, we go back to one of the few slides before, ensure that this child didn't stick anything in their mouth, and there's nothing that shows up in the airway like a penny or anything else that's causing this weird cough. I've had one of those kids do that. My child has done that to me when she was 2, swallowed a penny on her anniversary. It was the worst anniversary ever. No, it wasn't bad, but still, things can happen, and they stick things where they don't belong. So again, think of your differentials, think of what else is going on in this child, and so we can treat them appropriately. So treatment for croup. Some facilities use racemic epi. In my opinion, it's not necessarily a fix. It is a temporary improvement to airway swelling or edema that's caused by the virus. So not really first line, but I mentioned it here because a lot of people do go this route and throw it on there. But again, just know that you can have a rebound, a little later. So glucocorticoids, typically the first line treatment most facility uses dexamethasone. It can be given PO, IM, or nebulized. Hopefully PO is preferred. Nebulized, plus or minus, benefits. There are facilities who do tend to use that, and you have less systemic effects. However, PO is the standard of treatment or standard of care currently. And so one dose is typically your preferred. Occasionally, some more of the severe ones, some families, to make them feel comfortable, get written an extra 1 dose to take a day or two later if symptoms occur. And sometimes that's all they need to feel better and not represent back to your ER. IV form can be given PO and taste better. A lot of facilities prefer not. I've read that there are some issues with approval for this. So plus or minus, I've seen it done, but it is one alternative. And again, whatever gets the child to take the medicine or can get the medicine in the child, this is what's going to get you through croup. Typically, they improve within the first 24 hours after this, or even that day. I've seen many children, improve rather quickly. And so it does reduce the need for hospitalization. Some occasionally do, especially with hypoxia, but it's rare. Those are the very rare subset. So what else can we do? Obviously, talk about parents to humidify the air at home. That helps moisten that air and makes it easier on the epiglottis and all that's swollen. And again, avoid intubation if possible. This is absolutely the last line of treatment. If all else fails, this child looks horrible. Very rarely should anyone ever get intubated from croup. And so very easy to treat. Once you've seen it, you've heard it, you'll remember it. So we'll move on, talking about epiglottitis. So something similar, and this is why we talk about non-ill appearing for croup, but epiglottitis is a severe bacterial infection. And so it's caused by varying bacterial species. And again, our unvaccinated patients are at increased risk. And as we all know, there's a increasing number of families choosing to avoid vaccination in their children as a personal or religious reasoning. And so we have seen a slight increase across the nation with epiglottitis. And it's very important that we catch these early on, and the treatment is very different. So talking about the presentation, we think about the 4Ds. So a child that's drooling, they're having a hard time breathing. They have dysphagia, difficulty talking, and dysphonia. And so, these child may be in a tripod position. They're very, typically a high fever, and they're ill appearing. So to help differentiate between croup a little bit more, you typically don't have that barky cough. These kids are, very sick. And so the treatment, though, however, is where it gets a little difficult. And so we want to examine from a distance if possible, right? And so that's always the term. We want to be careful not to upset this child, because this is really an airway emergency. If you have a good anesthesia team, or you have an anesthesia team at all, they should be requested and readily available, as there's typically a lot of airway swelling. And so if this child is to decline, this will be a very difficult airway for your clinicians. And so if possible, avoid any painful interventions. Blow by oxygen if they need it. Don't put anything necessarily in the face, because we don't want them screaming. That will cause some more inflammation in the airway. And if you can, obtain a lateral neck radiograph, and we'll look at the thumb sign here. This is what a lot of people do tend to go to as well, these cross tables, where you see the arrow, and of course everything's very swollen. So the tube would, the airway is here, and then back sitting part of that tongue area here, the tongue's over here. And so swollen most of the airway, so very difficult to get in and see and get this lifted up out of the way to view the airway. And so that's why it's so important to have a good airway team available before you move toward any airway interventions if needed for these children. Sorry. So really, epiglottitis, I chose not to spend a lot of time, because again, antibiotics are key. Getting the airway established if an airway is needed. But most important, getting the child to a specialized pediatric center is #1 priority, and having a good team ready to go if this child does begin to deteriorate. So bronchiolitis we'll spend some decent time on, because again, we see this a lot. This is a large portion of our PICU admissions. Bronchiolitis is only diagnosed up to 2 years of age. Afterward, the airways are typically larger. and it's not a distal airway disease as significantly as it is in that younger population. It is a viral process, so typically we see any number of viruses. RSV is a big one with our younger children. That is the majority of cases. We will see, co-infection with rhinovirus and RSV, parainfluenzas, the influenza strain, coronaviruses, human metapneumoviruses. Adenovirus is really significant, and that can cause significant distress. And between RSV, the human metapneumovirus and adenovirus are the ones that do scare us intensivists a little bit more, because those children have an increased risk of cardiac issues and deteriorating with those diseases. That's the one they walk in, and adenovirus, the green, horrible green drainage in the eyes, green snot everywhere. That is typically associated most usually with adenovirus, and so easy to see. That's the one you don't want to get because you feel like death and just want to lay around for a few days for us. So typically worse in the younger and premature infants. Again, a lot of infants that are in the NICU, they do get vaccinated for these before or sometime after discharge from NICU. So you may ask if this child that presented has received the vaccination for RSV prior to discharge or previously. Smoking is a big factor associated with home. That does cause, airway inflammation, as it does for all of us. So typically on these kids that present with bronchiolitis, they do and can tend to worsen at day 3 to 5, and not always up to that day 7 of illness. And so very important to examine worker breathing, the ability to bottle feed, and ensure that airway is patent and keeping the nose clear, like we just discussed before. And so all those secretions and debris tend to trap in those smaller airways and make it more difficult, and they have a larger reserve that isn't used, and so not as well apt at getting air in and out sometimes when those upper airways are obstructed. Some of the symptoms associated with bronchiolitis: low-grade fever, fast breathing, runny nose can occur. You don't see it typically in younger infants, but you can see, occasionally with that. Cough is pretty significant at times. Wheezing can occur, and so we'll talk about that briefly here in a bit. Retractions, the areas that we spoke about, again, very vital and important to expose the child, especially keep them from crying if you can, so you can see what at baseline your retractions look like. Just know that when we're feeding, if we are feeding for any reason and crying, they do tend to look a little worse. So sometimes taking a minute, let them calm down, get mother or father to hold them, comfort them for a minute if they're not in dire straits and they're not hypoxic, obviously. And so again, poor feeding. If the nose is obstructed, they can't feed, they get dry quicker. Because of the expenditure in energy and moisture through our fast breathing rate. In the especially young or the premature population, apnea can be observed. It's really brief. The definition of apnea is really 20 seconds. Most people call that 5 to 10 seconds of breath holding apnea, but again, can be seen in some of these really sick small infants or premature infants that were sent home because they were doing so well. Oxygen sometimes, again, high flow nasal cannula is beneficial in that population, so you may or may not have that available at your facility, and that's why they come to me. Hypoxia is typically seen, and so oxygen, again, big key. Bronchiolitis treatment, and so very few do require mechanical ventilation. However, some do, and those are the ones that tend to worsen and move beyond our ability to properly ventilate with high flow nasal cannula or other non-invasive forms. There really hasn't been a severity scale that's been created that's beneficial to determine whether or not this child's going to go, A or B route. And so it's really based upon exam, work of breathing, severity of hypoxia, and real mental status of the child. How active is this child? If you've got a child who's, breathing kind of heavily, there are some retractions, but they're awake, they're looking around, Okay, that to me, that's a good picture. We could improve and still need to watch, but the fact that that child's up looking around and interacting is very, very beneficial to, me as a provider seeing that. Deep nasal suctioning, we've already talked about it several times. Again, I can't stress this enough. Ensuring that nose is open, getting anything out, whether you have an inline suction or a good yonker, putting some saline down there. They're going to cry, they're going to be mad, they're going to open their eyes for a second. Even taking a good, decent size yonker and putting it in the nose for a second, just lightly in the nose, it seals around that little nair. Don't shove it all the way in, but that in itself can even clear a lot of secretions out. Do that to both sides, a little bit of the mouth, get those secretions out. Be very careful when you do suction the mouth. Don't go too deep. Don't cause airway trauma. And so very important that we do that. You may find that 5 minutes from now, your child's the retractions have improved. And so doing that often enough without causing too much significant airway trauma or sometimes will get you through the process of not needing to transfer that child or provide increased ventilation modes. Albuterol, I'll throw this in here because, again, many of the guidelines say no, for bronchiolitis, albuterol is not beneficial. However, typically when they come to me, I do have a fair amount of kids who respond to albuterol. And so it's very important to assess the family. Does this child have any rashes? Do they have any rash, atopic rash? It looks like an allergic type rash. Many children do. Strong family history of asthma, or even a weak family history of asthma and wheezing in a child or diminished breath sounds. The child's sick enough that they may be requiring increased intervention. Albuterol can be beneficial. It's not necessarily proven to decrease length of stay. However, I have seen children do well and improve with some albuterol and occasional steroid who do respond to the albuterol. And then within 12 to 24 hours, we may be off high flow nasal cannula and they look like a different child the next day. And so, again, I get those very sick children. Occasionally in the hospital, it's those guidelines aren't necessarily meant for in-hospital children. And so our opinion is if you're worsening, it's worth a try. Continue on. So consider a chest radiograph. If you have an infant who's worsened, the retractions are worse, the hypoxia is worse. Typically, the hypoxia may be worse due to increased CO2. So I didn't list here as well. And I should have relabeled treatment to diagnostic studies. However, a capillary blood gas, because most people don't want to stick an infant's artery, and that's perfectly fine. We actually don't that often unless we specifically need to go that route. A capillary or a venous gas suffice very well. The CO2 for our practice, we typically expect a venous or capillary CO2 on a blood gas to be about 10 points higher. And so 35 to 45 is the international, this is normal for a CO2. So you get a CO2 back of 55 on one of those two, forms of gases. That's not horrible. That's probably close to upper limit of normal. You get one and it comes back to 80s or 90s. Well, then you probably have a problem, and increased CO2 can actually cause increasing or worsening hypoxia in infants. So you have to consider that there could be air trapping or elevated CO2 in infants when you're seeing hypoxia, and they may need increased modes of ventilation, high flow nasal cannula, et cetera, to help ventilate them a little better and hopefully prevent getting intubated in the future. But again, back to chest radiograph, you see these worsening children typically in these younger infants and toddlers. So if they are deteriorating or worsening, we will see a consolidation, especially that right upper lobe will collect. As we go down into the trachea, we have the two major trees, but there actually is one a little higher that goes off into that right upper lobe. That can get clogged with debris, mucus, and collapse that right upper lobe. And that's why we have an acute deterioration there. So CPT may be beneficial. Again, studies are rather inconclusive. Again, if your child's worsening, what's the worst that can happen when you're providing a little, percussion, hopefully moving secretions out, hypertonic saline, to hopefully thin or loosen, and acetylcysteine, mucomist, as some people treat. We do that with these children who deteriorate and have those on radiographic findings. And again, may provide benefit. They can worsen to a bacterial co-infection. A lot of times we'll see it with Haemophilus influenza. That's cultured out if we can get a good culture. For any reason we had to intubate. But antibiotics may be a benefit if the child is continuing to worsen in lieu of those findings. So very beneficial to keep up with that, and in hopes that we improve the child. Typically, they recover after that 5 to 7 days, and the cough can last several weeks for educational topics for your family as well. Labs are not typically beneficial, for the not severely acute child. If they worsen, then obviously reconsider, but most of the time you may have an elevated white count. Again, it's a viral process. We may have fever, and so sticking the child may or may not necessarily provide benefit depending on how ill appearing the child looks. An IV may be beneficial if we're not feeding, obviously, for hydration purposes. However, supportive therapy is really the majority of treatment for bronchiolitis. A humidifier, oxygen, and allow the course to progress. Again, so if you have a child with bronchiolitis who is not feeding well, typically an NG tube or an OG tube is preferred. The younger infants, an OG tube, because putting an NG tube is actually going to obstruct one of the nares, cause you to have increased work of breathing. And typically infants, or the smaller infants, can tolerate an OG tube just fine. It just means you as a nurse sometimes are going back in there and having to re-put it in at times, and it's okay. We don't get a radiograph every time. Assess your patient. If we're gagging a lot and having a really hard time, or the saturations decrease after you put it in, you probably put it in wrong, but the majority of the time it is going to go to the gastric content. So whatever your facility recommends, if for placement NG-OG tube, obviously recommend you stick with your protocol or policies there. But as practice, either one of those is beneficial OG for the younger population. IV fluids, typically if you're giving a bolus, 10 to 20 mLs per kilo for an NS bolus or LR, but NS is just fine if that's what you have available. After 2 boluses and you're considering another, well, we should be somewhere else. And your child's very sick probably with that much fluid coming through. Maintenance IV fluid, so we use the 4-2-1 method. Easy method to remember. 4 mLs per kilo for the first 10. So you're at 10 kilos, you're 40 mLs. 2 mLs per kilo for the next 10, up to 20, and then 1 for every one after. And so highly recommend you guys, if you don't know that, write it down. That's quick and easy, so you can check your clinician's orders or your orders if you're writing to know, okay, well, this is what we should use for fluids. But obviously, again, back to PO feeding, that is really the key. If we can get to there, that's where we'd like to be. All right, so it's 9:10. We've got a little bit of time left. So asthma care, I wanted to touch asthma care because we see a lot of this as well. And so asthma is, typically seen in low-income populations, minorities, children. It sounds, like a poor novel written here. But it happens in these populations more likely due to either, allergens or air quality, especially inner city, which we don't see a lot of here. The dirt, especially after a dirt storm, we may see an uptick of asthmas. Look outside, it's brown. Oh, we'll see about 2 or 3 asthmas tonight, and that's just to be expected. All of those things can cause worsening in these patients. It is a 3rd ranking cause of hospitalization in younger than 15 years. And if not treated well and not compliant, we see more often of it. And so very expensive to treat this disease. And so again, another one that we feel is important to discuss. So 80% of children with asthma develop symptoms before 5 years. And so again, as an ICU clinician, I see children, and I've diagnosed asthma in infants and toddlers, not very often, But when there's a strong history or a child's been in and out of the hospital several times already for wheezing or wheezing-like episodes, and they respond, they most likely, quack and walk like a duck, and they need appropriate treatment. Coughing and wheezing are the most common symptoms. When they're worse, they may not be wheezing, and so keep that in mind as well. Respiratory infections are triggers. So again, dirt, dust, infections, all of those things can cause an acute exacerbation of these children. Obviously, I've listed some viruses at the bottom. We've already seen these already. Stinking RSV, flu, rhinovirus. Man, those are bad stuff and the bane of our existence some days. And so I just put this slide up. I borrowed this from someone else. Just helpful to see, where we see the predominance in who. And so especially our Black population tend to be more prone to these. So we'll go real briefly, some pathological causes of asthma. Let's see here, kind of go off. So the pathophysiology of asthma is composed of airway edema, right? The airway is swollen. It's chronic edema. And so very important understanding what causes asthma and how do we appropriately treat it, which we'll come to. And so the muscles, the smooth muscles constrict, they get inflamed and they get trapped with secretions and dirt and grime and just gunk. And so got to get that out, got to clear it somehow. Eventually, if not well treated, it can cause remodeling in the airway, which is not good. And so you can see in this picture over here, a kind of a normal wall, and then this inflammation and dirt, grime, and gunk get caught in there, just not well. And so again, borrowed some of these things because they're really great, and I love making life easier. Your symptoms are only on the top of the water, right? Everything else is hidden underneath, and all these other problems. And these patients can go south quick. And some of you may have gotten patients who woke up and said, I can't breathe, and they deteriorate very rapidly or don't even make it to you. And so we don't ever want to get to that point. And so it's our job as clinicians, our job as nurses, when we see these patients, we have an opportunity, very important opportunity to help make their quality of life better. So common physical exam findings, decreased air entry, wheezing, maybe completely diminished. Big key, prolonged expiratory phase. When you listen and they're breathing in, but it's taking longer to get the air out, very important finding, consistent with asthma or an inflammatory air disease. Dry cough. It can become wet later as you treat them and they start opening up and moving things out, but you'll see that on the back end. We talk about increased AP diameter of the chest due to air trapping, allergic responses, rhinitis, conjunctivitis, sinusitis, all that inflammatory process, eczema, atopic dermatitis. Those are big keys. You may or may not see that. And your younger infants, who have that, they may be prone and at risk for developing asthma, especially if you ask the right questions to family members. And so I ask you to keep that in mind. We'll look at this graph. For age group, that atopic, again, we talk about that rash. As they get older, our risk definitely increases. The transient wheeze, again, RSV can have a transient wheeze. Or influenza in our bronchiolitis patients, and they can go on to develop asthma later on with those. We don't still fully quite understand the process with that, but there is a link to that that I won't go into. But just as a quick look at, okay, these are various things that could move on to asthma. So again, moving on, how do we manage in the ER or in your acute floor that you may or may not have? So oxygen, right? Number one key. So they may be hypoxic due to a VQ mismatch, not getting good air in because everything's inflamed and swollen. Air can't get in and circulate as well. So we want them to be well oxygenated. Albuterol is important. When I educate families on albuterol as we're in the hospital, even if they already know about albuterol, they say they all do, and I wonder sometimes because they're not very compliant. I like to describe albuterol for my terminology, and feel free to steal it and use it because I want everybody's life to be easier. I equate people using albuterol to calling 911. And I wish it was red. There's a controller that's red, and I wish they would change colors and make albuterol red for the MDI. But every time you have to use 911, if you are using that once, 2, 3 times a day, I tell the family, imagine you calling 911 every time you've done that, because you are rescuing yourself 3, 4, 5, 6 times a day. Should never happen. Okay. Educational topic there. But it allows, smooth muscle relaxation. Albuterol does not fix the problem. Okay. We've got to fix the problem. And very important to do that. So ipratropium, plus or minus, some facilities do an EBS, they do use it. It can be beneficial as well, short term, not necessarily long term. It is also an expensive drug and sometimes hard to get a hold of, depending on where you're at. So may or may not have the ability to add ipratropium to that, but it does provide some benefit. IV magnesium sulfate, 50 per kilo is a good starting dose, but it helps that smooth muscle relaxation as well. Can cause sleepiness, and if you're having to give a dose, you may want to check a mag level and determine, can I give another one later? We don't want the mag level getting too high, because again, we may make them super sleepy and just not real with it. Didn't go. IV terbutaline is one, and again, another smooth muscle relaxant. Haven't quite used the terbutaline very often lately. MAG seems to do pretty well. A couple doses of MAG sometimes where we get. It's been, like I said, quite a while since terbutaline, but it is there. It is available to use if needed, and if that's all your facility has, then obviously if it's needed, then that's where we're going to go. I suggest you go and read and study more about that. Epinephrine, sub-Q or IM. That's kind of one of those, another almost like you think last ditch efforts, but it is an alternative. It is an option because of that relaxation of the smooth muscle as well. The goal is to open the airway so we can breathe. We want this child to stay off of mechanical ventilation if at all possible, because that affects their ventilation. They will breathe, and they can do very well, contrary to adults who tire very quickly. Children, not near as much. Non-standard treatment, Heliox. Don't really use Heliox all that much. If I do, it's in that really severe, I've already intubated and we're having to think of other things, or even taking the child to the OR to gas them out and hopefully allow the gas to expand. Ketamine is another, again, don't use all that often, but it is an alternative or an option that can be used. Real briefly, I'm going to go over, the severity score. We won't look at this very long. I recommend you look it up and look at the asthma guidelines on staging questions. And the reason I bring this up, because it's important to ask questions. How many times a day are you using your albuterol, right? Those are very important, questions to determine, what is our true severity? How often are we waking up at night coughing? Once a night, once or twice a week, what is it? Give them an idea and let them choose if you have to. Ask the child, ask the adult. Don't necessarily just depend on the adult. If they're, 4 or 5, they may be able to truly give you a semi-close answer, because think about it, where are our kids sleeping? Sometimes all the way across the house because we don't want to hear them, and we may not hear them coughing and waking up at night. So get both perspectives. A child can answer questions just as easily. It may or may not be right. Take it with a grain of salt, but that's my practice. And so, ask them too. Hey, buddy, do you have to stop and catch your breath at school? Oh, yeah, a little bit. Or, can you keep up with your friends while playing? Or, do you have to take breaks very often? Those are all important to classify our severity of illness and where should we be with our treatment guidelines, right? And so they may not be diagnosed, or they may be very poorly underdosed and not treated appropriately. You want to keep them out. Just a quick picture of all these things. I know it's very blurry. The reason I wanted to keep this one in here was you can see just there is a lot to choose from. My preference is typically albuterol, right? Because it's cheap, it's easy to use, best way to manage, and it's easy to get. lot of people like Zopanex because the heart, I don't think it works very well. I think it was one of those miracle drugs that came out, but in my opinion, because with the heart rate's not an issue. The heart rate's going to peak at some point and it's not going to go any higher. They do just fine. They need to breathe. And so albuterol is a great drug still. And then of course our controller or a combination down here. I like Symbicort in my severely ill kids or who come to the ICU. I max therapy out every time, because I like a step down approach and our pulmonology team agrees. So quickly running through real quick, almost out of time it looks like. Consider controller therapy in those with greater than 4 episodes of wheezing in a year. If they got admitted to the hospital for asthma, they need to be on a controller. Plain and simple. They got admitted, they need something, and make sure in conjunction or communicate with their primary physician, whoever it is. Anytime I start a child on a controller, again, I max therapy down to step out because I want to destroy the symptoms and get them to a better quality of life. And so we step down therapy, and I always communicate with our PCP. So very important to consider that. The parental history. Atopic dermatitis, we talked about sensitization to aero allergens, all that stuff floating in the air, fomites, carpeted houses, all of that, can worsen us. And so food allergies, and wheezing apart from colds, all that's important. So let's see here. And so poor response to asthma medications, non-adherence to prescribed regimen. Again, they say they're taking it, but I guarantee you most of them aren't. Many of these people, if they are taking it, they may just be poorly controlled and they need better control therapy. Technique is a huge problem. I really prefer, and even if I send toddlers or infants home, we will still use the nebulized. However, an MDI, using the little puffer, can be used on anyone, and I prefer it because you don't have to carry a machine around. Well, how do I administer it? Well, they need an aero chamber, and it can be written for. And the aero chamber attaches to the MDI, and there's either a little mouthpiece or you wrap for a mask, and you shove it on their face. And guess what? You give your puffs and hold it on their face for 10, 15 seconds. They scream like they're going to do with the nebulized medicine anyway, and you're done. Oh, and the parents will love you for it. And that's really the best way to go. And that's how we have transitioned our practice into doing that over the last several years. It's just far more beneficial. It's easier to carry around, and they're not lugging electricity or a nebulized machine everywhere. They still need one for backup, but again, just a good alternative. Ineffective drug control or dosing interval. Again, the rescue med albuterol is very important, but the controller is just as important. And knowing that it takes about a week is what I tell families to really start working. That's why they're on oral medicine for a little bit. And then moving into the controller, taking several days. So morning and night, it's got to be done as prescribed for an extended period of time. So good education is very important as nursing staff and clinicians, that we educate our families over this. Psychosocial factors. Are they moving home to home? What is their living environment? How many siblings are there? Financial aspect, all that's very important, and appropriate treatments there. So people, prescribe antibiotics, cough medicines. Not a big fan of cough medicines, but they are a little helpful in some situations, but our cough is good. Over-the-counter alternative medicines. So people going out just trying to treat with whatever, not necessarily fixing the problem. Different responses to controller medications. Some kids aren't a lot, and even maxed out, they may need more, vice versa. Obviously, other complicating medical problems, such as chronic sinusitis, vocal cord dysfunction, GERD, all of those environmental allergies. So again, education is key. I really like this. I kept it here because it's cute. It's got the little girl holding the MDI and the mask. I really love that down at the bottom. A young child can do this. Better compliance and less hospitalization using these methods. Again, all the pollutants, viruses, smoking, all those bad things. We want to use this less often. So real briefly, as I'm trying to run through, and because I thought I had a little bit more time, getting an initial exam as a triage nurse is very important. We use CAS scoring, and I'm going to show that on the next slide. But getting vitals, oxygen saturation, if you can. This is our facility, how our facility goes through. If unable, they try to begin a treatment within 20 minutes as it RTs, you know, such a large ER. I think our ER is like 60 some beds or so, constantly moving, constantly going, a lot of patients to see. So nurses need to be able to own their patients just as well. But oxygen greater 90% is important. Getting our initial CAS score, and then they activate the standing delegation. So I'm not going to spend a lot of time on this, but getting a good exam, a good history is very important, and then triaging, deciding where to go. So using our setup here is our CAS score, obviously is aged dependent, what their respiratory rate is. And so provides, you know, different ages with respiratory rates, and then, you know, scoring depending on where they score here. Retractions, are there any? Subcostal, intercostal, you know, very self-explanatory. Can't, you know, where do they fall into this? Okay. And so what do we use from that? So this is our guidelines that our ER tends to use. It's very beneficial. And so depending on their CAS score kind of helps you down the road of where do I go? What do I treat with? And where does my patient need to potentially end up, or do I need to consider ending up later down the road? We use continuous albuterol up to 20 milligrams in certain patients an hour. And so that sounds like a lot, but I promise you they do find, yes, the heart rate increases and it reaches a peak and it doesn't go any further. Your patient needs to breathe. They need the albuterol. And so it's very important, but continue to assess them, assess their fluid status. Do they need a bolus? Because again, we may need to fill that tank a little bit. They may have come in a little dry. And then magnesium is a big portion. I notice a lot of our kids that come in very sick, they fall into this, you know, CAS range of 6 to 9. And so a lot of that is followed. Make sure you reevaluate frequently for deterioration or improvement, so you know where to go from there. So respiratory rate is very important. Heart rate, I like to include blood pressure. I really wish this was in here. I think blood pressure is very key, and that is usually one I fall back onto is we don't do blood pressures enough in kids. And I do tend with prolonged albuterol tend to see a little bit of a diastolic hypotension later on. Not an issue in the emergency department, but as an ICU clinician, that does come into play a little bit. And yes, it's a last vital sign to go for kids, but I still think it's a critical vital sign to address. So include that in there. Ensure you're documenting all of this, documenting your patient. That's, as documenters, we have to have a history, you have to have a story to follow. So, and I won't touch more on that, but hypokalemia is transient. Typically, you know, if you see that, that's one I wanted to hit. It does improve with resolution of using continuous or high dose albuterol. However, if it is low, then treatment is okay. To add treatment, they may have tremors, dizziness, nausea. All these things can occur with it. But again, the tachycardia maxes out, and they typically do very well. I've had kids on continuous for days. We get down and low as soon as we can. So real quickly, we'll come through, and if anybody wants to chime in. So, you know, you have a 7-year-old that come in, 35 kilo, respiratory rate of 20, accessory muscle use, none, dyspnea, speaks and senses, wheezing, have a little bit of, you know, expiratory wheezing. What would you do? Anybody want to throw something out there? What would your practice do? You didn't know this was going to be interactive. Nobody. Okay, fine. We're going to go. So typically on this, you know, this is pretty easy. So we're going to go look at the CAS scoring, right? And so what CAS score would you give this patient? And so treatment's up there in red, obviously, but 7-year-old 35, they've got a 0 for respiratory rate. Okay, not tachypnic, no accessory muscle use, very, very mild symptoms. And so prednisolone 2 per kilo. The load is usually 2 per kilo for your steroid. Some facilities have gone to just using dexamethasone, and some are saying, okay, a two dose course of dexamethasone is sufficient. I still think there's a lot of study that needs to be done on it, but that may be something we change in the future. That's, you know, our goal is to improve our patient. We want to reduce our overall steroid load, especially if we're getting a lot of steroids. Causes a lot of endocrine issues. We don't want it. So we've got to find a better way. Hopefully the dexamethasone will come out and prove to be much more beneficial down the road. Real briefly, again, we'll go over, let's see here. This one's saying respiratory rate 20, subcostal retractions, counts to 7 in one breath. And so expiration, inspiration. So respiratory rate of 20 is at, maybe a little elevated for a 14-year-old, but not horrible. Let's see here. My phone's going crazy. Respiratory rate there going through, so 20 for a 17-year-old, greater than 10 years. And so we fall into the 1 point range. Subcostal retraction, another 1 point. Counts in 7 in one breath. Okay, so another 1 point. And expiratory and inspiration throughout. Okay, so let's see what 1, 2, 3, 4, 5. So we have about a 5 or 6 here with that. And so if we go to that, our CAS of 6, obviously great. So I don't know if your facilities have guidelines. Again, this is a good method of how we go around and treat. Asthma can be treated and needs to be treated very well. And as nurses or as whatever you are on this, we're all important, and we all need to come through and take time to educate so we can provide better care for these patients. Because we all want good outcomes, and I prefer our kids stay closer to home if they can. And so any questions? That's really all I have. Hopefully that was beneficial to you. I want all of you to feel comfortable caring for kids. And if we do have to accept the kids, great. But I want our team in the region to provide the best care for our kids so we can get them back home and back to playing and doing what they should do. Just enjoying life. Anybody have anything? Let's see here. I'm going to go through the questions. Is there any questions listed here? Doesn't look like it. Well, okay, that's all I have. And if nobody has any questions, I appreciate you coming today. Again, hope that was beneficial. If there's any other topics that you want, please feel free to reach out to our outreach team. We'd love to fill in as best as we can. Thank you.
Thank you, Clayton.
Yeah, absolutely. My pleasure. Thanks for sharing some stuff with me. I really like the asthma setup that you had.